Treatment. So this is the treatment done for both veterans. So this is the example for the first veteran. So 1 month before beginning prolonged exposure therapy, the patient was treated with the selective serotonin reuptake inhibitor, or SSRI for short. Citalopram at a maximum dose of 40 milligrams daily. Although SSRIs have established efficacy for treating OCD and PTSD, the patient continued to have functionally impairing PTSD symptoms, including compulsive checking behaviors. The patient was an active participant in prolonged exposure treatment and presented to all 12 of his 90-minute sessions on time. So he went to all of his therapy. The in-session treatment exposure exercises consisted of vivid retelling and visualizations of the traumas he experienced as intrusive memories and nightmares. The imaginary exposures began with this most frequent and distressing intrusive memory and subsequently focused on less distressing intrusions as the patient began to experience symptom relief. The patient's homework consisted of in vivo exposures to safe situations that the patient had been avoiding. Examples, he'd have to go to the post office to pay for his bills, or go to the food court at a mall during a weekday. The patient's intrusions responded fairly quickly with regard to both symptoms, frequency, and intensity after in-session treatment exposures exercises. After 5 sessions, the patient scored a 40 on the PTSD checklist and a 22 on the BDI, and he expressed having some relief from his intrusions. However, he retained a SCID diagnosis of PTSD and reported having difficulty habitating into his vivo exposure exercises. During the next period of treatment, the patient's compulsive door and window checking were reduced as a result of the in-home intrusions, or in-home therapy, which were often from the impetus for his checking in the first place. However, the actual behavior reinforcement of checking whenever he did feel anxious continued and remained clinically significant. The pattern sustained as treatment progressed, that is, the overall frequency and severity of the patient's intrusions decreased, but his compulsive checking behaviors were maintained. The treatment team hypothesized that the behavior reinforcement he received via immediate anxiety reproduction on checking was interfering with his progress on in vivo homework exposures. That is, the patient's self-reinforcing checking behaviors in response to anxiety at home made it more difficult for him to tolerate any anxiety long enough to experience success outside the home in regaining pre-pathological social functioning. Attempts to assign him in vivo homework were not checked, were unsuccessful. As he explained, it's so easy to do. And what he's talking about is his checking behaviors. It's so easy to do and so hard to stop. Attempts at cognitive restructuring were also largely unsuccessful, perhaps because the patient's checking progress was already ego-diagnostic. As the patient explained, sitting here in the clinic, I know that a bunch of Iraqi insurgents are not going to bust in my door, but at home when I'm amped up, I can't help myself. I'm up and check it. So these visions and memories are just kind of popping into his head and he can't really do anything about it, even though he knows. The eighth treatment meeting consisted of an in-home exposure session where response prevention was added in the vivo exposure paradigm. The patient and therapist sat in the patient's living room and waited for naturally occurring sounds, like his neighbor's car door closing, dogs barking, trucks going over potholes, and anything else that was kind of going on outside of his house. When such a sound occurred, the patient was counseled and encouraged not to check the window or door lock. The patient used self-reported subject units of distress and other skills he had learned via earlier imaginary in vivo exposures to monitor his anxiety. So he used his therapy to help not want to check with what was going on around him outside. Anxiety, including sounds, occurred about every 4 minutes on average. The patient was able to refrain from checking behaviors and was also able to habituate to normal neighbor sounds within the session. The treatment team hypothesized that the patient was able to experience such success because the increased support of accountability resulting from the therapist being present in the ecological context of his symptoms. Once the patient habituated to the normal sounds of his neighborhood in the presence of the therapist went outside and periodically made additional noises. The patient knew that the therapist was going to do this and was instructed not to check the window. Although the patient knew the therapist was making the noise, he reported having a more difficult time not checking because the noise was a little louder and closer. The patient described muscle memory involving springing towards the window on hearing the sounds and having to sit back down after he had caught himself unintentionally off the couch. The therapist had also noticed such automatic movements during earlier exposures. These movements may explain why cognitive reconstruction, emotional processing of the patient's traumas were ingrained in his memory. So it was just habit, and he couldn't help himself. And then after more prolonged therapy, the checking behaviors at home interfered with the patient's frustration tolerance, while attempting out-of-home in vivo exposures cannot be empirically confirmed. However, subsequent to the home visit, the patient was much more willing to engage in the homework assignments and experienced greater success in doing them. And then finally, after 12-session treatment, the patient no longer met criteria for SCID diagnosis of PTSD. His PTSD checklist score was 23, and his BDI score was 9. So eventually, most of his PTSD symptoms went away. And then the treatment for the second soldier was he was also treated with the drug citalopram, and he was also at a maximum dose of 40 milligrams, but only for 7 weeks before beginning prolonged exposure therapy. And he did continue to have significant PTSD symptoms. The patient was an active participant in the prolonged therapy as well. He arrived on time to all 15 of his sessions. Early in his treatment, he evidenced an especially low tolerance to his PTSD-related psychology arousal during his initial imaginatory exposures. And these exercises included speeding heart, shortness of breath, and tingling in his hands. So he was starting to work up an anxiety attack. And they would start to do exercises which involved helping the patient to become aware of and tolerate his psychological symptoms without over-interpreting the significance of how somehow dangerous or out of control. The exposures were conducted without the use of significant external traumatic cues, that is, target physical symptoms were induced through doing jumping jacks, breathing through a straw, and rubbing both hands with force. And the patient continued to do therapy for 10 weeks, and then in the final 10-week treatment, it consisted of an in-home exposure and response prevention exercises. The patient and therapist practiced leaving the patient's home and getting into his car without checking under the car or car hood for bombs. Much like the first patient described above, this patient also exhibited an overlearned muscle memory, where it was just habit for him to want to go and check under the hood. After 30 consecutive trials of getting into the car and getting out of the car without checking, the patient was able to get in his car and start the engine without experiencing distress. The patient's behavior logs over the next 5 weeks indicated a successful decrease in car checking, going 7 days in a row without checking. By the last week of treatment, the patient also began to experience success in his vivo community exposure exercises, so he had more success when he went out in public, shopping during the day, he even went to church, and taking his wife out on dates. And then at the 15th session, the patient scored a 32 on the PTSD checklist and a 17 on his BDI. So from that, with treatment And with lots of treatment and possibly medication, people's PTSD symptoms can go away after time, but it does take a lot of work, and you really have to stick at it.